1% is quite a high figure. So I've really revamped my question about, family history of glaucoma. Can we ask Nani to share the screen?
Yes, he's in the process. I just told him. Yes.
Okay. Anything? Can you see my screen now?
Yes, we can see your screen.
Okay, great.
But we are not on the slideshow yet.
No?
It's hanging. We are seeing your screen, but at the point of the documents, we are not yet playing the presentation.
Really?
Yes.
Even now?
Yes.
Okay, good. So I wanted to show this, to show how SLT is done in case someone has not come across SLT. Really, it's a gonioscope that is just placed on top of the cornea, and the laser beam is used, is aimed at the angle, as you can see here, at the filtration angle. And this is where we want to put our spots. That's at the angle.
Dr.
So what? Yes.
Could you try resharing the screen again?
What happened?
No slides. We are not seeing the slides.
Stop share. How's that?
Yes, now we are seeing the slides.
Okay.
Thank you.
All right, so let me start again. For those who have not encountered SLT, SLT is done using a gonioscope, and we aim the laser beam at the angle. And the aim, well, for this study was to get 100 spots, 360 degrees. So they didn't do the 180 that we are sometimes advised to do. So that's 25 spots per quadrant. A few patients, they didn't manage to do the full 100 shots, but they tried as much as possible to get in those 100 shots. So as part of the introduction, for us, prevalence of glaucoma study that was done in Nakuru for patients above the age of 40 shows prevalence of about 4.3%. Now, one other reason why we would want to do this study is because drops have their own side effects, and prolonged use of drops actually predicts failure of surgery later on. So patients who have been on drops for a long time later on tend to have failure of trabs or any shunts that are put in later. Drops are also cumbersome and expensive. Some of our drops are for our people may not be as affordable, especially if you're putting them on combination drugs and also multiple medications. So SLT has been with us since around 2001. So that's about 20 years, and still the uptake has not been as good. But now there's an increased push towards giving SLT as a first-line treatment for glaucoma. So it is safe, it is painless, it is not perfect. It's not permanent. So they say you need to repeat it after about 1 to 5 years. As we'll see in this study, most of the patients by 3 years, as I said, the follow-up period was 3 years. Most of the patients by 3 years still had had achieved their target IOPs. But still, despite it not being permanent, it can be repeated. So the LIGHT study, LIGHT stands for Laser in Open Angle Glaucoma and Ocular Hypertension Study. So that was not an error, that was them trying to make it memorable. So the LIGHT study, their methodology, observer must being that for every patient, they would do serial OCTs. They would start with the IOP at presentation. They would do OCTs. They would do visual field 24-2, and they would take the IOPs as I mentioned. And then they would determine the target IOP. They used percentages rather than absolute values. So some patients, the target IOP was 20% reduction, other patients 30% reduction, of course, depending on the kind of patient you have, the age, the severity of the glaucoma. So there's a protocol that they were following to determine what percentage which patient would require, what target IOP each patient got. And each eye had its own target IOP. I mentioned also that it was a multi-center study, and they took outcomes at 3 years. Now, their primary outcome was quality of life. And we'll talk about that. They also are looking at cost, which I also mentioned. They wanted to also look at the efficacy. Is it comparable to the drops? And they also, of course, wanted to look at the safety. So patient characteristics, they had a really good number, 718 patients. That is 1,235 eyes. That to me was a really good number. Then 72% of patients had both eyes enrolled. We know glaucoma tends to be bilateral rather than unilateral. So 555 had open angle glaucoma as opposed to 163 who had ocular hypertension. Remember, this was for both open angle and ocular hypertension. So some patients, so they divided the patients one-on-one. So they took the patients who had ocular hypertension and then distributed them to each arm. The patients with mild distributed them to each arm like that. So the severity was equal on both arms. So 356 patients got SLT, and then 362 patients got eye drops. Now, the eye drops, they followed the standard protocol. They are not, they didn't discriminate against the number of eye drops, which we'll see later. So if you needed one, you'll get one. If you needed 4, that's what you got. And the escalation was also predicted by the serial, the follow-up OCTs and the visual field and the IOPs that they did at regular intervals. So I mentioned 20 to 30% depending on the presentation of the patient and other factors. 360 degrees laser, we tend to advocate for 180 degrees fast and then observe, but they chose to go with 360 degrees and 100 non-overlapping spots. Drops could be either single or multiple, so each patient got what they needed. And then progression was monitored by masked observers. This means that there was, to avoid bias, there are people who were set aside to determine escalation. So they got a file where they could see patient, the starting IOP, the OCT and the visual field that they started with, and on the next visit or the subsequent visits, how the patient is doing. And then they would determine, is there a need for escalation? So escalation could be either eye drop. So this could be determined now by the clinician. So you have a separate set of clinicians who would execute what is said to be escalation. And escalation is according to protocol. So escalation could be repeat the SLT. Escalation could be add another drop. Escalation could be, let's move to trabeculectomy. So those are the people who are masked. Obviously, you couldn't mask the patients to whether or not they're getting SLT or drops, and the clinicians could not be masked on that aspect either. So on to the outcomes. So they used the European quality of life assessment tool, which was assessing visual acuity in terms of far vision, near vision. They were also assessing depression or anxiety when you're on these medications. They're assessing mobility. Is the patient able to go about their usual walk from here to the park or bring themselves back? Were they able to do their daily activities, put on their clothes? Remember, they have a very high percentage of elderly patients. So therefore, the treatment needs to allow them to continue with their daily life. So those are some things that they were looking at. So those are the levels that they were looking at. Are you comfortable? Are you a bit comfortable? Or are you uncomfortable? Or are you very uncomfortable? So for both arms, in terms of quality of life, whether the patient had SLT or had drops was quite the same. There was no statistically significant difference in the two arms. So quality of life, patients were not really complaining about the quality of life, whether they were on drops or whether they had had their laser treatment. The only difference in these quality of life assessment tools was when they administered the glaucoma symptom scale. And this is quite predictable. I mean, the drops will cause, think about prostaglandins, they'll cause hyperemia, they'll cause discoloration, which is, you can imagine darker pigmentation in a patient who has a blue eye. So one eye is brown and the other one is blue. Sunken eyes, patients who are asthmatic on timolol, although that was looked into. So only in the glaucoma symptom scale was there a difference between the two arms, and that was actually pretty predictable. Other results comparing the two, now at 36 months, 95% of patients after SLT had achieved their target IOPs, which is really good. Now, more than 75%, more than 3/4 of the patients only did one session. Now, the criteria for repeating the treatment was that if the first time there was a drop in IOP, then it's okay, you could do a repeat. But if you didn't achieve any drop in IOP the first time you did SLT, then that patient will not get a repeat. So a very good number didn't need any additional eye drops. This is not to say that you don't need, this is not to say that you don't need eye drops after SLT. SLT is also good for reducing the number of eye drops that are needed after a patient receives the SLT treatment. So 78.2% didn't need eye drops, but again, that leaves us with about slightly more than 20% that did need additional eye drops, 1 or 2. So, I mean, 1 eye drop or 2 eye drops. There are some patients who needed more than 1 eye drops over and above the SLT. Now, 23 eyes deteriorated, meaning they progressed and needed addition. So those are the patients who needed add 1 drop, add 2 drops. But none at the end of the 36 months required trabeculectomy. So the escalation was in terms of addition of eye drops. 13 patients by the end of the study required phacoemulsification because they developed cataracts. On the other hand, a very good percentage of patients, 93.1%, achieved target IOP at the end of the study. That's the 36-month period. Then 64.6% needed only a single eye drop. That's still a pretty good number. Then 36 eyes deteriorated, and therefore some required even additional eye drops, and 11 ended up getting the trabeculectomy. Compare this with the SLT team that did not require any trabeculectomy. This was interesting that 25 patients in that arm ended up requiring phacoemulsification, and that actually led to another question about whether or not eye drops cause formation of cataracts. So there was no conclusion on that, but it was an interesting thing to note, and I think a basis for studies of how many patients, glaucoma patients, develop cataracts once eye drops are started. So let me move this. Number of medications that are required, I think I've alluded to this. 16, now the first slide might be a bit confusing. The number of patients who initially started on drops were still continued on that line. So if later they were converted to SLT, some patients actually went ahead and requested to be moved to the SLT team, and that happened. And then some required trabeculectomy. So that's why you have none as first on that list. So what we had said earlier was that about 65% of patients in the eye drop team required only one medication. And then 2 medications, as you can see, they're about 20%. About 6.5% required 3 different types of eye drops, and then 3 patients required 4 different types of eye drops. By the end of the study, the number of eyes that were not on target were 37. Now, on the SLT team, this we had discussed that about 78% of patients by the end of the study period didn't need any additional medications and were still on target eye pressure. 12% required at least 1 eye drop, and then about 4% needed 2. You have 4 patients that needed less than 1% that needed 3 eye drops, and 1 patient who required 4 different types of eye drops. Then 27% by the end of the study period had not achieved target period. So this is to say, by the last visit at 36 months, this is the number of patients who had moved away from the target IOP and therefore would receive further treatment. It's just that now at 36 months, they are collating the data. One of the things we're also looking at was the side effects, and this is the side effects. SLT, I think personally, I was expecting higher levels of uveitis. That's what I was looking out for in my mind when I was looking through this study. So I expected higher levels of uveitis, and I expected a spike in IOP. So I was very pleasantly surprised to find that the levels of uveitis, in fact, uveitis was on both arms. Because remember, some of the medications also cause uveitis. So you had uveitis, 2 patients who had uveitis. This actually was also a similar number in the eye drop team. IOP spike day 1 after treatment in 6 patients, but then by day 2, 5 patients had gone back to normal, and then 1 patient needed further treatment. After the SLT, like needed an additional eye drop to lower the IOP. So this was a pleasant surprise for me. Eye drops, these ones we know the side effects of timolol, prostaglandins, and the carbonic anhydrase inhibitors, all those. But mostly the ones that people complain about most are the prostaglandins, the lash overgrowth, the hyperemia, pigmentation of both the conjunctiva and the iris, the sunken eyes, which can be actually quite dramatic, allergic reactions. I remember I had 1 patient who was allergic to BAK and could not afford the few medications that are BAK free. So cost is really a great factor for our people. So finally, cost implication. For them, SLT costs about 28,000 Kenya shillings, an equivalent. And then eye drops, when they were doing the math for the period of time, the duration. So they're following the patients up for 3 years. So the total came to about 63K. So you can see the difference in that. So if you extrapolated another 5 years, if this SLT is going to be successful for a period of about 5 years, then the figure goes even higher. Of course, as I mentioned, not all SLT patients will be drop-free. Some will need an additional drop, 2, 3. We even had 1 patient who needed 4 additional eye drops. But still, looking at those figures, it is comparable in terms of outcomes. And in all patients, the IOP target achieved, the visual outcomes were actually quite comparable on both arms in this study. So really, we're not saying one is better than the other. So for those who don't have access to the SLT machine, you're doing well, control using the eye drops. But if there's access to SLT, the earlier the patient can get onto the SLT, the better in terms of cost and also in terms of achievement of IOP, target IOP. And I think that's my last slide. Yes, please. Yes. That's what I had for you today. I invite any questions.
Thank you. Okay, sorry. Thank you, Dr. Wanjiku. Can I comment? I know I'm not I don't know where Frank is, your moderator, but I just, sorry?
He's in already.
Oh, okay. I just want to comment on SLT. We've been doing it. I've been doing it for about 5 years in Aga Khan. And I can say the results I've seen are pretty good, pretty comparable to what you have just shared. The only thing I wanted to add is, yeah, we do 360. We don't do 180 at all, because to get maximum effect, do 360. If it works, it works. If it doesn't, it doesn't. Repeatability is one of the advantages, but somehow I think African eyes will accept this SLT a lot, because out of the eyes I've done over the last 5 years, I think I can count not less than 10 patients that have had to repeat the SLT. And another thing I also want to comment is that SLT does very well in juvenile open angle glaucoma. I don't know, somehow these young guys, you do that SLT once, their pressures remain at 10 forever. So it somehow, for one reason or the other, the young guys do very well. And also, patients who have, just on the comment on the use of medication, the patients who are on so much medication, their eyes are hyperemic or they have side effects to BAK, like you're saying, and you do SLT on these patients, get them off the medication, in as much as sometimes when they're on the medication, they have achieved their target. So you find many patients are maybe on several drugs and their eyes are red and they're having a lot of side effects. Yet, yes, their pressures are 10, but quality of life is very poor. These patients, you do SLT on them, get them off the medication, especially the ones that are causing a lot of side effects, and they're very happy. So sometimes we don't do SLT to the pressures can still be very good on medication, but we have to do the SLT to get the patient off the medicine that is causing them to have a lot of side effects. Also, patients who are not compliant, there's some patients who come today, they'll say they've used their medicines, tomorrow they've said they haven't. Those are patients you need to do SLT. So the exfoliation, pigmentary glaucomas, we do SLT on those. So I must say, at least for the last 5 years, I'm sorry I haven't done a study on my on my patients, but I've done, most of my patients are Black, 98% I think are Black. So probably that's an area that we can also study SLT in our setting. Thank you.
Thank you. That's very valuable feedback, especially knowing that SLT works even better. I mean, if we have 78% success rate on primarily white population, Doc, let's do that study.
You're welcome.
Wanjiku, are you hearing me?
Yes, we can, Prof.
Yeah, sorry I'm on the road, but thank you for that excellent talk. It's good to start having those ideas of improving in technology. And I think I agree with most of the things that Sheila has talked about. I just had a question. There was this interesting finding about the cataract and drops. Was that finding statistically significant of more cataracts in drops? That's number one. Number two, I didn't get you from the beginning. I wonder what eye drops were being compared with SLT. What was the protocol? What was the methodology?
Okay, so about the cataract, it was kind of an incidental finding that they found about 11 patients who were on the SLT arm developed cataract, and surprisingly more patients who were on the eye drop arm had more cataracts, 25. So they really didn't go further on that study, but they did mention that there is a theory going around that eye drops predisposed to cataract, and that would be a basis for another study. So it was significant, statistically significant, but there was no further comment on that matter. Number two, you asked about which eye drops. So they followed the standard protocol, the European guidelines, and each patient was given eye drops depending on who they are and what kind of other conditions they have. For example, if a patient is asthmatic, and that's one of the questions that they asked the patients to fill in, then they would not be put on any combinations that had timolol. However, I have been talking about patients being on 1 eye drop, 2 eye drop, 3 eye drop. So they are putting any class of medication. So they were not comparing with any one particular eye drop. So they're just comparing with patients on whichever eye drops are you achieving your target IOPs. I hope I've answered your question.
Yes, I think the other issue I wanted to speak about is the cost. You know, the cost, first of all, is the cost to the doctor. You know, SLT is a machine that can only treat glaucoma. It doesn't do anything else. I mean, if you have an argon laser, you can use it right from the lids to remove your eyelashes to the to glaucoma, to do ALT, to some angle closure glaucoma, to your diabetic retinopathy. But unfortunately, you will only buy SLT to treat glaucoma, and so the cost to the doctor becomes a bit high. And that's maybe why the uptake of SLT has not increased here, because of the cost for institutions or individuals to afford the machine. But it's true that if at least the capital investment can be found to buy the machine, then the ongoing cost could be cheaper, at least to the patient, and drops even in our circumstances. Thank you.
Well, that you can have a YAG machine, but I think it has to be a car size, and then you have an attachment. So you only buy the attachment, so you can use it for YAG capsulotomies and all the other lasers that you are talking about, and then the attachment enables you to do the SLTs. I don't know what Dr. Marco has to say about that. I've only read about it.
Hi, Wanjiku. This is Dr. Jyoti here. How are you, dear? All right?
Thank you.
Good. Nice presentation. 2 or 3 things I just wanted to ask you. Where was the study done? Has the study been done on African eyes? I have done study along with Dr. Harold Gekle in 2002 when I was studying in university. We did it on the African eyes. I don't have the data at hand, but I should be having some of the data in Lions Eye Hospital, which I had done. After that, I did even the SLTs in Lions Sightfist for 2 years on Asian and the African patients. We had an SLT machine there in 2005 and 6. That data as well with the Lions, because they didn't allow me to take it. But in that, I just found some few things, is that whatever results you will get in the Muthee eyes for SLT are not the same as on the African eyes. That was one of the comparison I was trying to do. And within 3 months of time, my 70% of the patients got the IOPs, which were high back again and had to be put on the drops. The other 30%, it took almost like some took 1 year and some took 14 to 16 months, as far as I remember vaguely, that I had to put them on the treatment after 1.5 years. Now, the other thing which Dr. Sheila Marco has just mentioned, that you do 360-degree. And that time, I think in 2001, when SLT was introduced, and 2002, when I did with Dr. Harold, I was doing it at 180-degree, and we were overlapping 2 times the spots, the laser trabeculoplasty, the laser beams. So the accessible areas on that. And as far as I agree with Dr. Sheila Marco that I got better results with the younger patients, younger African patients and the open angle glaucomas who were on 1 drug treatment rather than who were having 3 drug treatment or 4 drug treatment. I didn't find any SLT which was quite useful. And I feel that we need to do, not to take all the Muzungu data, but to do some studies on our African eyes or the Asian eyes, because there is pigment there, a lot of pigment, and a lot of pigment dispersion occurs afterwards. And again, you go back to the normal square one. That is what I would comment, and if you have something to say on it. The third thing I wanted to ask you, you have mentioned that with the drops you are getting the cataracts, which also you answered to Dr. Dan Kiage that you are not knowing which drops caused the cataracts. Was there a assessment done on these patients to find out whether there was any early cataract for them initially, even starting, and what was the age group that they got these cataracts? You see, so it might be a coincidence or it might be related to the drops. I'm not saying so, but was there anything which was evaluated accordingly to find out that whether the cataract was in relation to the drops, or it was age related, or was it found in the younger patients who would not get any age or senile cataracts or something like that, or whether it was caused due to the laser trabeculoplasty, maybe if there was any laser beam went onto the lens. So this was my the question.
Thank you, Dr. Jyoti, for your comments. Nice to have you with us. So you asked about where the study was done. Sorry, you want to say something?
No, you continue.
All right. So the study was done in the UK. They did it in 6 different. It was a multi-center study where they took patients from 6 different centers. Then the number, because it was done in the UK, as you said, so 70% of the study patients were whites, then about 20% were blacks. So I agree with you 100% that this study needs to be done now on primarily black patients so that we can see whether our whether our population also has similar results as Dr. Marco suggested. Finally, about the cataracts, I think they just decided not to chase the cataract down, what do they say? To go further into the cataract. They said it was an incidental finding, and you're very right, it could be because of the age distribution. So no, they didn't comment further other than saying they noted that in one arm we had more cataracts, but you're right, that could be the reason why one arm had more, because they didn't do an age match, they did a severity of glaucoma and the type of glaucoma. That's the matching they did rather than the age matching. I hope I've answered your question.
Hi, Wanjiku, may I ask?
Yes.
One, wasn't it related yes, to that arm had more traps?
Yes, gone.
That arm had more traps than the other. Then the other issue was just a challenge to the Glaucoma Society. Since it looks like SLT, I mean, from what Kiage is saying and Sheila, it looks like SLT works so well. How come they're not pushing SLT? Why isn't there a bit more push to get this thing? Because even just the cost comparison you showed, it is staggering. So why hasn't this thing been pushed? And you know, and then the other comment was for Dan. There's a YAG SLT machine combination that exists. We have one actually. So yeah, that exists.
I think I will allow Dr. Kiage to answer his questions.
Yeah, actually, you know, our anecdotal findings, though we have not done a study, is that Sheila and I have been very happy to use SLT, and it's worked very well for us. It's got these indications, and wherever those indications are there, it does very well. I mean, I mentioned about the cost that you're getting this SLT. Most of them, I mean, there are some, I think, which are coming now made from India, where you can get an SLT and a YAG altogether at about $25,000. But most of the good SLT machines have been in the upwards of 50. So now that is the only thing that it treats. So to convince the heads of hospitals who might also be the glaucoma specialist to buy that SLT as opposed to another machine like an argon laser, which can do several things. So the cost and the number of patients you're going to treat and what you do with that machine, the return of investment has not been justified, at least to the people who do the math. But clinically, yes, it is. And maybe as we go ahead, it may not be the priority when you compare with other things that you want to buy in terms of the finances, but clinically it's a very good thing. And maybe if you have done with your priorities, and then it can come next.
I also want to comment on the cost of the machine. It's as Dan has said, the original machine, the original people who designed this machine, that machine is very expensive, but apparently it's the best. I'm trying to remember the make. Dan, what is the make of that machine? It has just flown through my head, but it's the one that we were lucky enough to, sorry? It started at L. I can't remember. It has just gone. I think it's old age. Anyway, so we have it in Aga Khan, and it costs between I think 5 to 7 million, anything thereabouts. And but it's only used for selective laser trabeculoplasty. No other. There's nothing else that machine can do. There are the other ones that are. Sorry.
You mean Luminis?
Yes, Luminis. Yes, that's the there are other brands like what Dr. Kibata has said there in their hospital that also has a YAG machine that's more versatile. I tried using it. I don't know how it's working out. Wendy, we had worked on some patients together. Maybe Wendy can give us an update on how it's working, because at least with the YAG, it's a more versatile machine and it's more cost effective. In terms of more patients having SLT done, also the price is prohibitive, because like in Aga Khan, per eye is about 20, maybe 24, 25,000 per eye. So most of the patients you see who can benefit from this are the patients who have insurance. And these are usually the younger guys. And you see glaucoma, you don't find many people under probably 60 who have insurance, who can afford. So there are all these things that are limiting us, but maybe with time, as the machines get cheaper and as the technology becomes more common in our setup, the cost of all these things will go down. Wendy, I'm curious to know how you're doing with the SLT at CTI. I think is Wendy somewhere?
Yes, I am here, Dr. Marco. So, hello, can you hear me?
Yeah.
Yes, so unfortunately, I've not had the opportunity to use the other machine that Prof and Dr. Marco are referring to. So I can only say about the combined YAG SLT laser machine we have at CTI Hospital. And for me, so far, it works very well. I know one of the challenges we had even when Dr. Marco was there training me on how to use it is that the aiming beam is not very, they're concentric rings, which sometimes can be a bit difficult to focus, especially if you have a rather uncooperative patient, as opposed to on the YAG side of the same machine, where the aiming beam is just one spot. So, and I remember Dr. Marco was comparing and complaining about that, but I've not had a chance to use any other machine, so I can't say too much about it. But so far, the results are good.
Thank you, Dr. Wendy. I don't know if Dr. Sheila has something else to add on that.
No, I think I've said all that I can. Thank you.
Okay. There was also a comment from Choksi. There is a comment, we really need to do many more studies in African eyes, which we have been alluding to from Dr. Sheila to Dr. Kiage, Dr. Kibata, but there was also a asking, was cap disc ratio taken in consideration before treatment? Wanjiku.
Yes, as I said at the beginning of the treatment period, during enrollment, they considered the mild, moderate, and severe type of glaucoma. So yes, that was part of the consideration. They also considered the mean deviation. So they didn't take, so they also considered the vision and the mean deviation on visual field. So they didn't accept mean deviation higher than 15 decibels, and they didn't take a visual acuity less than 636. Someone asked about cataracts prior. Now, that was one of the criteria that they should not have had any cataracts prior to enrollment, but they are allowed to have had an uncomplicated phaco surgery and not have any other, be on any other medication for any other condition like allergies or any other eye drop. That's what I mean. So they should not be on any other eye drops to be enrolled onto the study. I hope that makes things clearer.
I see, I don't think there is any other question from the chat.
I think let me make another comment, especially what Dr. Kibata was talking about.
Okay.
I think these machines are going to be more useful if people get together and buy one and use one. I think there may be some challenges on accessing the one of our account because it's an institutional one, and you need, rights to use it. But I think that
Dr. You're breaking up. We're not getting you well.
It can be a nice machine that can be bought, and easily accessible. Oh, sorry. You can get me. Can you get me now? Again another time.
Dan, we can see you, but we can't hear you. You're on mute.
Doc, we are not
Can
hearing.
you hear me now?
Yes.
Can you hear me now?
Yes, we can.
Okay. What I'm saying is that it's possible if one SLT machine can be bought that is accessible to many of us, somebody could make a business case to that because it should be used. I think now other people like Dr. Muthee are interested. We are adding to the numbers who want to do SLTs. And NHF also pays for it, not too much, maybe something like, I think, 15,000 shillings. So that is something. So it's a starting point. So I think let there be a business case where we can get, one SLT for Nairobi that is more accessible to most people.
Okay. Dr. Kibata here has a comment that NHIF covers SLT and doesn't cover eye drops, which would mean that it makes a stronger case for the SLT to be made available. I don't know if you have any comment for that, Dr. Kiage.
Yeah, basically that's what I'm saying. That is true. NHIF covers for SLT, and so it's possible. Some of these was have NHIF, so it gives more points to the business case of getting an SLT somewhere, and we can all come and use it because we can't all afford one in our practices.
Okay. Thank you for that. I think since we have no other questions on the chat, we could give this evening our today's sponsor, that is Allergan, for a 5-minute presentation before we come to a close for the day. Annette?
Okay, thank you, Dr. Kalu. Let me start by saying good evening to all the doctors who joined the virtual meeting. Today I'm sitting in for my colleague Pauline as she has an emergency. So I'll briefly take you through our presentation. If you could kindly, can I go ahead and share my screen?
Yes, please share. We are not seeing the screen, Annette.
Just a minute. What are you seeing from your end?
No screen yet.
Okay. Is it visible?
Yes.
It's visible right now, yeah?
Yes.
Okay, so I'm sure maybe on a daily basis, or especially for the glaucoma specialists, they get to actually see these glaucoma patients. And this being a glaucoma week, of course, the glaucoma patient is the focus point. And these patients, of course, are normal people like me and you going through life as usual. And we all know that glaucoma is, the silent thief of sight. So of course, this greatly has a negative impact on the quality of life. And that's when we say every moment matters, with every millimeter matters. So let me start by looking at one of our key brands, and that is Lumigan. Lumigan is bimatoprost. It's the only prostamide with a dual mode of action. So Lumigan will act on both the uvascular and trabecular outflow. The uvascular, it will act by 50% and trabecular outflow by 35%. What makes it different, what makes it stand out as a prostamide, it's because it's clinically different in terms of the biosynthesis, the pharmacology, and the clinical potential. So just to recap on that, let's look at a study that was meant to show what is the clear difference that makes Lumigan stand out. So it's a Crichton AC et al. Study that was done. It's a multi-centered prospective open label observational study. And it was just comparing patients who already put on another therapy and then switched to Lumigan. So the first group were on latanoprost and then switched to Lumigan, and there was a clear difference where there was an IOP drop of up to -3.1. The second group was on travoprost, which then they were switched, of course, and then there was a clear drop of -2.8. And then lastly, the group was on beta blockers, which had a very significant IOP pressure drop of up to -5.7. And on top of that also, it also showed that Lumigan was well tolerated following the switch from prior IOP lowering medications, with up to 94% of subjects presenting with none to mild hyperemia after 12 weeks, which a hyperemia is a class effect, but Lumigan showed a higher tolerability factor. The other brands we also have for glaucoma that protect the priceless, this being the eyesight, of course. Having just mentioned Lumigan, which you can always, start a patient right off from it, because as we said, every millimeter matters to this patient. It's one of the #1 drops for lowering the IOP. It has a very superior efficacy in a 2016 meta-analysis study that was done. It's also very reliable and consistent, and it's also time-tested. I'm sure many of the doctors out here have used it for quite a long time. And that is bimatoprost, 0.01%. Then we have Gunfort, which is a fixed combination of bimatoprost and timolol, which also has a superior IOP lowering efficacy factor versus other fixed combinations in the same class. It also provides good tolerability in daily practice, and it's also the #1 fixed combination glaucoma drop. Then we have alpha-GAN, which is bimodidine. You can always use it as an add-on therapy for added protection. Also offers IOP lowering to help protect the patient's sight. It's more effective as an add-on, as I've just mentioned. Efficacy versus carbonic anhydrase inhibitors in 10 years of a meta-analysis study that was also done to prove that. And of course, the added advantage of having purite as a preservative. And then lastly, we have Combigan, which is also a fixed combination of brimonidine and timolol. Also has a superior IOP lowering factor. It's also more effective as a fixed combination compared to dozalamide and timolol combination. And 92% of patients reported improved ocular comfort when they were switched to Combigan for those who are on dozalamide. So for Allergan, for a portfolio of glaucoma anti-glaucomas, we have the 4 drugs. Lumigan and Ganfort are OD doses, while Alphagan and Combigan are PD doses. And of course, glaucoma as a disease entity is one of the priorities for Allergan, known as a leading ophthalmology company. And other than that, having said that, I just wanted to recap on that and make it brief, just as a reminder. So thank you so much. I want to thank OSK for partnering with us and letting us also host this meeting today. That's it from me, Dr. Kalu. Thank you.
Thank you, Annette. Thank you very much for that presentation. I would like to thank everyone for attending today's CME. Thank you, Dr. Wanjiku, for such a stimulating presentation and contributions from all our doctors on board today evening. So we have come to the end of our presentations and our CME today. The next one will follow in the next 2 weeks. We will be sending emails to remind you of the same. And please remember to send in your name and the institution where you are at to the host OSK. It's listed as OSK on your participants window for CPD points. Thank you and have a good evening. We are free to leave for today.